Hi, my name is Dr. Debra Pinals. I'm the Medical Director of Behavioral Health and Forensic Programs for the Michigan Department of Health and Human Services. I want to talk today about engagement because I think it's a very important issue. And if you're watching this video, chances are you have an interest in assisted outpatient treatment. It's important to realize that even with the court order of assisted outpatient treatment, that engaging the people we serve is going to be a vital component of the provision of care. It's important to realize that community behavioral health plays an essential role in keeping people engaged in care. We know that's one of the challenges for people who are on an AOT order. They have had a history very often of not staying in care. And so what we want to do is make sure that we're doing everything we can from a clinical perspective and from a systems perspective to keep them engaged and deliver the care that will make them want the treatment. For AOT, engagement is essential. AOT is an evidence-based intervention and is aimed to help individuals with serious mental illness who meet certain criteria. Often these individuals are unable to recognize their illness or their need for treatment, or for a variety of reasons may have dropped out of treatment and then have symptoms that create risks and potential harm to themselves or others. Now, individuals that have inconsistent engagement have many different challenges. For example, they may encounter and need frequent hospitalizations. They may have housing instability. They may have repeated contact with law enforcement or even time incarcerated. They may have recurrent suicidal thinking or repetitive suicide attempts. And they may have substance use disorder with relapse on substances. So it is our job as treatment providers to help these individuals maintain their treatment and stay engaged in care. And people on AOT orders really required concerted efforts on our part and creative engagement efforts so that they can be supported to be maintained in care. So what is engagement? In 2016, the National Alliance on Mental Illness put out a paper called Engagement, a new standard for mental health care, in which they said many people with mental illness are handcuffed during psychiatric crisis, discharged to parking lots, jailed, turned away from services, and left to live on the streets. Many never experience what should be the most basic standard of care in the mental health system, a healing connection with a mental health professional, dignity, respect, and a sense of hope. And this is what we're trying to emphasize here, a healing connection with a mental health professional, with a peer support worker, and with a variety of people that might interact with an individual whose job it is to help this individual stay engaged in care. In this regard, community mental health is really an unsung hero. There are so many barriers. People are working under very difficult conditions. We are always under-resourced in community mental health, and yet working hard every day to help individuals who may have very complex needs. And the job of the community mental health worker is to stay and keep that person engaged in the care that can be so challenging. Engagement work is really hard. It takes a lot of ourselves because of so many demands on our time and so many difficulties for individuals that have to be overcome. We have made a lot of progress in the area of engagement. What's better today? Well, we know a lot more about person-centered planning. We know that even with an AOT order, that an individual who is engaged is somebody who feels like they are the center of the care that they are receiving. And our care delivery has to be based on what they want and what their goals are. We know a lot more about motivational interviewing, how to help people, for example, with substance use disorders who may be not quite ready to make the changes that will help them move forward towards their goals. And our techniques around motivational interviewing can help them move more towards those goals. We've done a lot better on systems integration, helping look at physical health and behavioral health together, looking at behavioral health and criminal justice more in an aligned way so that we can help individuals who are caught between these systems. We've made a lot of progress around the peer workforce and helping individuals and realizing that we can help them by bringing peers into the workforce to help individuals so that they can have beacons of hope who've made it and are working and helping with their own recovery and giving back. We've done a lot better around self-examination, how we look at our own activities and our work so that we can continue to improve. And there's opportunities continually for new innovation. There are still challenges ahead as we look at delivering AOT-related services. We have to continue to bridge services across where there may be gaps. We have to really identify linkages that matter, making sure that people are getting those warm handoffs from care provider to care provider. We have to really understand for this particular individual who's under an AOT order, why is the door still revolving? If they are continuing to need hospitalization, why is it? If they're having a difficult time maintaining their medication, why is that? We still need to work to understand how we help people along a continuum of supports. There's no one solution to people with complex conditions, whether it's a medical condition or a behavioral health condition. So we have to work to meet those challenges. Relying upon the engagement new standard of care that NAMI put out in 2016, we have to think about engagement and sustained treatment as a major challenge with our behavioral health populations, especially those with justice involvement, and maximize success by enhancing alliance and trust with clients we serve, integrating that peer workforce, using those motivational interviewing techniques, and again, being person-centered, even when there is supervision or oversight and a court order that is involved in the treatment mix. Community mental health is the hub to coordinating care. There are so many elements to care. We have an AOT court order. People may still go to the emergency room for their care. There's substance use services. They may have correctional, institutional care if they do happen to get arrested and be held in a jail, for example. There's psychiatric hospitalizations, coverage through Medicaid very often, and then these community-based health services with community mental health often serving as that hub. The more we can coordinate, and that is one of the roles within AOT, is to help that individual navigate a complex system and be there to be that glue between these different, often siloed services. These are some of the vital components within CMH. CMH offers many different positive strengths, years of history and experience, very strong grounding in the community and the community ethos and what it needs and where services can be made available. These incredible network connections, attachments both at the state and federal level, integrating component parts within its system, an able workforce, and frankly, a willing workforce. Anyone working in the CMH workforce is obviously coming to the job because they want to serve the population and do public service. Now, when we're providing services, it's really important that mental health providers, peer workers, everyone think about something that's been talked about for a long time. I've been in this field for over 25 years, and we talked about the therapeutic alliance. This old paper by Johnson and colleagues really looks at this idea of measuring ourselves. So when we meet with a client, what if we rated each of our interactions on a regular basis? Would our views be the same as the service recipient or their family? For example, if you look at the rating scale, they say, for every service, look at, did you feel heard, understood in an encounter? You can ask yourself, did I think that the client was heard, understood, and respected? And did they think it? If we're not seeing things the same, then perhaps our engagement isn't going to be as strong as we think it is. So this is one of the ways that we can measure our own work. We also want to build safety networks and realize that it's not a single person that's going to save the world. It's really a community and a network. And so we want to think about what are the individual's needs that we're serving and how can I, as an individual, help that person? Where are their family and friends that we can help connect this individual to so that they feel connected? What about peer supports? What about the community at large? What about spiritual connections that may help shape that individual's success in their recovery? And even the criminal justice system, if the individual does have a criminal justice probation officer, for example, how can they be leveraged as a partner to build a safety network to help the individual that we're serving stay engaged in care. So in conclusion, I just want to say that there are evolving approaches to individuals who may be subject to AOT orders, and that the partnerships matter. We have to think of individuals on the case level, on the local level, and also working with state systems to help leverage the strengths of the system to help drive change and support for individuals on that very, very local level. So we want to understand the communities in which people are living and their own personal framework. We want to look at it from a diversity, equity, and inclusion lens, and really continue that network development and use feedback loops for problem solving as problems arise. Our jobs are hard, but the individuals that we are serving deserve the best from us. And part of that is to really look at engagement and realize that engagement is a tool that we can utilize that's just as powerful, if not more powerful, than anything else we can do, from court orders to medication. It's really using our personal selves to help that individual stay engaged. This training is presented as part of the Michigan Assisted Outpatient Treatment Toolkit. To learn more, visit http://behaviorhealthjustice.wayne.edu/AOT.